And modern problems require modern solutions.
All right. Led by Johns Hopkins med students, synthesizing COVID news from reputable sources. And then, of course, they're protecting themselves. This is not Johns Hopkins. This is a couple of medical students. Actually, I don't know how many. Their content is very packed. A lot of good info here. I would say maybe literally not run by Dave Chappelle. I would say perhaps we need to make these slides a little bit less busy because it can be overwhelming. But this is awesome content that they're doing. So, and they have like a legit logo, unlike me. All right, COVID up, the number 2, and then date. COVID up to date. Check it out. All right. So here's how this is going to work. I'm going to pause when she gets to stuff that I will react to in terms of whether I think it's accurate or not. And I will try to be as bring in as much real evidence as possible, not just anecdotal stuff. Be quiet.
As practitioner, I am licensed and certified. I am not on the front lines. I have a friend in New York City who's on the front lines. All right, here we go. And for her safety, she cannot come out and say these things. So I am her voice. I'm not going to name names of people or hospitals for the safety of those involved. But this is her account, okay? I am her voice here. I'm going to tell you what she has told me. She wants this to get out. Now, I'm sure this is not the case everywhere. I'm confident. I have friends that are in other places. They're on the front lines. They're in ICU. And it's not like this everywhere. But in New York City right now, in some of the hospitals, this is what is going on. People are sick, but they don't have to stay sick. They are killing them. They are not helping them. She used the word murder, coming from a nurse who went to New York City expecting to help.
All right, first pause of the reaction. Okay, so this is a nurse practitioner who is relaying a message from a nurse working in a hospital in New York City who doesn't feel safe to voice their own concerns. I'll start with this. I think this is fair, what she's trying to do with her intentions, okay? Second thing, this nurse is saying murder. That's a strong word, but we need to have some tolerance for very, very strong feelings here. So that's not really turning me off in terms of not taking this seriously. From the chat, a New Yorker doesn't feel safe to voice their concerns. Yeah, because I'll tell you this, being on the administrative side, for physicians, it takes quite a burden of behavior or otherwise to be removed from your position, but for other healthcare roles, including nurses, there's just more people in the nursing occupation, and it's harder to keep your job protected. So anyway, we're going to keep going.
Patients are left to rot and die. Her words. She has never seen so much neglect. No one cares. They are cold and they don't care anymore. It's the blind leading the blind. Now, a couple of weeks ago...
The blind leading the blind is a relatable experience that I have had. Don't really clarify about people are cold. Is she talking about her co-workers that are emotionally acting cold, or the patients are literally cold? Is this left to rot and die in a metaphorical sense or literally? It's not really clarified.
I was on with some nurse friends of mine, and we were discussing different medications that could be used to potentially help people. Doctors who were reporting around the country that they were using a combination of medications that were helping people. People were not dying when they were on these medications. They were getting better. Those medications are not being used in hospitals in New York City. What is happening is that they're putting people on nasal cannula. If they require more than 6 liters of nasal cannula, They get intubated, they go on the vent, or they get trached if there's not enough vents.
All right, I'll stop there. This is something that happened. This was more or less the standard of care until we realized that actually people can tolerate hypoxia quite well, and the outcomes of ventilated patients is quite bad. Now remember, this was posted like 4 or 5 days ago. I don't know when it was actually written. So this is clearly outdated in terms of the approach to hypoxia. The no vents and you get trached. I mean, you're still gonna need a vent. That's weird. So I, that doesn't really make sense to me. But then again, this is the nurse's words. I have heard nothing about traching patients because there's not enough vents. Because what are you going to put through the trach? Come on.
They don't get high flow, no non-rebreather, no non-invasive ventilation, no CPAP, no BiPAP. They're on a closed system, the ventilator, versus a CPAP or a BiPAP for fear that it will spread the virus.
Okay, so again, this is an accurate description of the way that we started out doing things as New York City was surging, which is the recommendation was if you're failing on 6 liters of nasal cannula, you intubate somebody. Keep a closed system, prevent aerosolization. That's a risk mitigation. So that's that. Again, I don't know the exact timestamp of when this was made, okay? But if it's being put out 3 days ago, it's very misleading because people are thinking that's still happening now. It's clearly not. That is not accurate right now. And for the sake of timestamp, it's not accurate right now. It's April 30th, 2020. At least a couple weeks, possibly longer. We've known that we do cooperative awake proning and we go down the step ladder of nasal cannula, high flow nasal cannula, positive pressure, non-invasive, etc. Okay?
Which, by the way, I know a nurse in Florida who was fired for exposing that about CPAP and BiPAP and patients being put on the ventilator, like straight away to the ventilator, to be on a closed system. The patients don't know any better. They don't have family with them. There is no one there with them to advocate for them. So they are scared and they give consent. The ventilators have high PEEP, high pressure, which then causes barotrauma. It causes trauma to the lungs. Dr. Siddell.
So I'm just gonna say this. She's reading off of a message that a nurse sent her because the nurse that wrote it didn't feel safe to say it. Okay. Yeah, but nurses, you're saying isn't that what the nurse is there for, to advocate? Yeah, but you can't always advocate safely without putting your employment at risk. I come from not my current hospital, but many other hospitals that I've heard of and that I've been to. Not really safe environments to advocate. If you advocate, you become a problem person. Yeah. What I was going to say is this. This person is a nurse practitioner. I don't know what her role is, if she's like a primary care nurse practitioner or what, but I do critical care. I make vent management decisions, and the way that she is talking about they put these people on high PEEP and cause barotrauma is overgeneralized and oversimplified. And again, I think that's misleading.
Cameron Kyle Siddell, a few weeks ago, put out a video. He's in New York City, and he put out a video saying something is not right, like we're not treating this correctly. We're doing something wrong. This doesn't make sense. They pulled his video from YouTube and they took him out of ICU.
Sorry about the low quality on this. I'm not sure why. Dr. Siddell, I did watch that video. What was interesting is that he was comparing the pattern of pulmonary edema and the disease process to high altitude pulmonary edema. This is something that we've covered on here before. even though COVID ARDS is uh, not like typical ARDS, that doesn't mean it's like high altitude pulmonary edema. And again, what she's saying is, I don't know how dated it is either.
Because they couldn't have one doctor going against the grain, going against their protocol. The protocol is propofol or some kind of sedation because they're on the ventilator and IV antibiotics. There's no.
Wow. That's really not, that doesn't sound like a problem to me. Giving appropriate vent sedation and covering a pneumonia process empirically with antibacterials until you know more. Not a problem.
No hydroxychloroquine. They're not using that combination with Zithromax. They're not using zinc, vitamin C, high doses of vitamins A and D. They laugh.
Where is that coming from? Vitamins A and D? I have not seen any data on that. You guys, don't make me laugh with this hydroxychloroquine again. Plus azithromycin. Oh, A and B. The bottom line is giving vitamins is fine, but thinking that you're actually treating by giving vitamins, there is no data for that. And there's so much misinformation. We're going to stick to what we know. I pulled the treatment guidelines from my hospital system. I'm going to read this directly to you, okay? Emerging data on the use of hydroxychloroquine and chloroquine calls into question the efficacy and safety of these agents. The routine use of these agents in the treatment of COVID is not recommended until treatment trials currently underway are resulted. Okay? And I will tell you, so far, there's nothing really promising about hydroxychloroquine. So far still, being upset that all the patients are not getting hydroxychloroquine is, that's weird. So it shouldn't be the standard of care.
This is what she's told me. They laugh at that. She says this is a nightmare. It's out of a horror movie, and I don't want to be a part of this. There are people who are a full code, and yet if they crash, they're not doing compressions because it will spread the virus. Full code, not doing compressions. Family is not there. They have no one to answer to. No one is being held accountable.
All right, this really sucks. I'm going to treat this seriously, okay? As a member of the ethics consult committee for my hospital system, this stuff gets discussed. What do you do if somebody who is a known severe case of COVID and ARDS, if they arrest? Are we resuscitating them? This is certainly something that an argument could be made that the survival of someone in general who has cardiac arrest is low, meaningful survival especially. Now, take that person to be a COVID patient. The survival is that much lower. Factor in the time it takes to put on the appropriate PPE, go into the room, and provide the standard of care for compressions. You're looking at really low likelihood of survival. So in many places, it's being openly discussed about the ethical risks and benefits of resuscitating patients when you're in a crisis area, and New York City certainly is. That doesn't mean everything is fine and we just go with it. It's deeply traumatizing to see a patient not survive, and then they're full code and you don't go in and you resuscitate them. That's very disturbing. I certainly appreciate that. But I don't think she's aware of these things. So she's presenting it as if it's just a hospital system is not interested in trying to bring patients back to life. Misleading.
A code was called and no one came. So sometimes they're not even resuscitating people. Again, left to rot and die. They're not given blood.
This is too emotional and, again, appealing to people's feelings as opposed to the actual concepts of medical ethics and the actual science behind it too.
because we know that the blood is not oxygenated in these COVID patients. We know that. There are doctors all around the world sounding the alarms. These are the drugs that work. This is the pathophysiology of the disease. This is what's happening. And for some reason, it's not changing. Even though we know, some of us know what's going on, nothing is changing on the front lines. They stay in the same PPE all shift, except for the top pair of gloves. So 2 pairs of gloves, or I don't know, maybe more than 2, but they're only changing the gloves on the outside. Gown, mask, whatever else stays the same because all patients are COVID patients. So if it's a COVID floor, it's all COVID, but it's not because some of them are rule out COVID. So even if they're rule out COVID and they're not COVID, they're going to get COVID because they're using the same PPE all shift and they're carrying that contamination to all of the patients. They're not changing their PPE.
This is not okay. But then again, we know that there are some COVID patients that are being grouped into the same room. There are whole COVID zones that are all a negative pressure zone. You're either in it or you're out of it. So PPE is an issue, but yeah, I'm with you guys. This is, again, it's not great, but very misleading because it makes it seem like these are intentional decisions or this is just us not caring on an administrative level. Believe it or not, there are plenty of people in the administrative system that do care.
They're not going into rooms. So they're running long tubing into the room so that they can manage the tubing from outside of the rooms. So if they're not going into the rooms, that means they're not assessing the patients.
Shout out to all of the nurses that are running IV tubing and even the screen of the vent outside of the room for the sake of being able to make adjustments more quickly for the safety of the patient. Also, you can assess the patient because you have these round objects that are embedded into the front of your face. And at the front of these round objects, there's a little translucent area where light goes through. In the back, there's an optic nerve. It carries that information to your brain, and then you can do critical thinking based off of that. If you can see a patient, that is an evaluation, okay? So shout out to these nurses who are figuring out that you can actually run a pump and put a vent management screen outside of the room so you can address issues more quickly. It is not accurate to say that just because you have a pump outside of the room, you're not assessing the patient. These patients are more critically ill. You can see with your eyes and make adjustment and then still buy enough time to get in, okay? Once again, misleading. The scissor system. No, don't do this, man. Again, you can't fault her. She doesn't really know all this stuff. She's just trying to advocate. So she's the messenger. I am not really so concerned about the messenger. I'm concerned about the message, and I want to make sure I give my reaction to it, okay?
As frequently as you would be otherwise assessing your patients. They are not doing rapid result tests. You're lucky if you get results in 5 days. Okay.
That may have been true at one point. It's not true in surge areas right now. Question from chat. Who is she advocating for? A nurse who anonymously sent her their thoughts. You guys, I'm going to remind you, just like Bernie Sanders, I'm once again reminding you, do not attack the messenger, okay? We're looking at the message itself. If she doesn't know, and she's, this is someone who's for sure thinking that she's trying to do the right thing. She shared some anti-vax type articles. Okay, well, that's another strike against her being able to understand the standard of care and medical evidence. And this will be the only time I actually look at her stuff, I guess. But still, we're looking at the message.
This is coming from my friend who is in New York City right now on assignment, who went there to help, and this is what she's finding. It's a horror movie, she says.
It is a horror movie.
Not because of the disease, but because of the way it's being handled.
Reasonably true as well.
She said we need help, and people are sitting there waiting in the hotels. Money, I guess, it's being paid for by FEMA, and yet they're still understaffed. And there are hundreds of people, hundreds of nurses in the hotels waiting to be called onto a shift. So there is manpower enough if the goal were to actually save people, but resources are not being utilized properly or to full capacity in a way that maximizes the patient benefit or improves the outcomes. The records and charting are crap. And now some of these hospitals in New York City are probably crappy on a good day. So you add in the fear of COVID and the fear of the whole pandemic and forget it. So if you're in a crappy hospital with crappy nurses, let's face it, all of us nurses have worked with crappy nurses before who don't care. So now you add in this, forget it. And they're having people do things that they can't do. So maybe things that they're not proficient in. So maybe a nurse who's not familiar or comfortable with using a ventilator.
All right, let's just brush past this garbage that she's talking about how hospitals are crappy and nurses are crappy. She came from a nursing background. How can you do this to your fellow field? Not okay. Self-hater, I guess so. I mean, you got to realize I have a lot of gripes against fellow physicians who do things in a lazy way, or don't care to stay up to date on things and don't provide the standard of care, bedside manner, whatever. I get that. But to say that there's crappy hospitals full of crappy doctors, these people are trying their best. Not accurate.
And it's that figure it out mentality. Figure it out. These patients are critical and they're crashing. Figure it out.
Shout out to all the nurses doing their best to figure it out right now. And basically doing street medicine because they're trying to get the best of the resources that they have. There are battlefield promotions, nurses that do not have an adequate amount of critical care experience who are being asked to do critical care work. This is not something that we want to do in a normal time. Shout out to them for doing their best.
So nurses are being celebrated as heroes, right? We see how like the fire trucks and the police are like lining up and practically having these parades and celebrating them as heroes. And
every day there's parades. I've seen a couple on Instagram. That's about it. Where do you live?
Don't get me wrong. I'm sure in some parts of the country and other ICUs, I have friends that are working on the front lines in ICU and they are good nurses. And some of them are heroes. But we have nurses being celebrated as heroes who are killing people. They're not heroes. And they're being brainwashed to think they're doing something great just by going to work because they're brave enough to go to work. Well, what are you doing at work? You're certainly not saving people if you're not even running codes.
All right. I have tried to be very measured, and she's clearly not reading off of what the nurse is saying at this point. She's just freeballing it. And this all of this stuff she's saying does not pass the vibe check. So it's like hard to keep going.
You're not even going into patient rooms. You're a coward. You're hurting people. You're killing them. You're contributing to the problem.
So I'm just going to make a point that this little rant right here is cowardly and is contributing to the problem. She could offer to go and help. If she cannot help, hopefully there's a legitimate reason why. She could express her wish to go and help, but instead she's calling other nurses cowards. Vibe check equals not passed.
I know I'm going to get hate mail for this, and that's fine.
Let's just hear that again.
You're a coward. You're hurting people. You're killing them. You're contributing to the problem. I know I'm going to get hate mail for this, and that's fine.
Why is it fine to get hate mail? Perhaps you're making statements that is generating hate mail. You guys, I have an account of 44,000 Instagram followers. I'm not like bragging, but I have been personally attacked on my Instagram account a handful of times total. Think about the number of impressions that I have had on Instagram and the engagement that I have. The number of comments and likes. The number of times eyeballs have seen my content. I am not getting hate mail. I'm not getting hate messages. It's not fine. It should be a signal that something is seriously not fine. and I'm not saying everybody knows what's best, because there's a very disturbing amount of misinformation that a lot of people believe. But yeah. Guys, this is 7 minutes and 40 seconds out of 10 minutes, and I just can't do it all, so I'm just going to go here. That way there's only 50 seconds left.
Their jobs. Do not give consent for intubation if you don't want to be intubated or your loved one to be intubated. Demand non-invasive or less invasive ventilation methods.
All right, this was a little thing where she is saying you need to dictate your own care. Now, I don't have a problem in an individual scenario of advising somebody to say yes or no to something. But to sit in your home and make a video and post it and give that kind of advice that could potentially kill people is seriously unbecoming. That is not the Hippocratic Oath. Whoever commented on her eyebrows, please, again, we're just talking about the message.
As soon as you give that consent, you might not come out of it. Now, in some cases, it might be appropriate. We just don't know. We know that it's being used inappropriately in a lot of cases.
So since we don't know if it's appropriate or not, you're suggesting that everybody refuse to be put on a ventilator? That's sus. That's highly questionable.
And that the ventilators are making people worse.
There was a 90% mortality from what I saw on ventilated patients in New York City. 90%. So she is right about the fact that people on the vents don't do well. Anything else?
Please share this video, make it go viral.
Okay, we're done. That's it. Please. Oh, God.